Dr. Kalubovila to take the podium. Thank you very much, Dr. Kandy Society, President KSM, for giving me this opportunity to talk to you on abnormal liver function test and NAFLD. Actually, I wanted to speak to NAFLD, but Dr. Sunishka Ponnampuram is live via KSM organizing this CME event, wanted me to describe or talk to you on abnormal LFTs as well. So first part of the lecture, I would mainly focus on abnormal LFTs. In the second part of the lecture, I would speak to you a little bit on NAFLD. Most of the data and recommendation and guidelines were taken from the EASL, European Association of Study of Liver Disease. So I should mention that as well. So just to remind what the liver is, because we all know that liver is important for so many functions in the body. From the faculty days, we know it's one of the main synthetic organ in the liver. Synthesis of protein, coagulation, coagulation factors, and bile, and most of the metabolic process take place in the liver. Gluconeogenesis, glycogenolysis, glucogenesis, fat metabolism, urea ammonia cycle, as well as it's a storage organ. It acts as a storage organ, glucose, vitamin, copper, and iron. Detoxification, as well as the site of production of so many hormones, including like growth factors and thrombopoietin as well. So when you evaluate someone's liver function test, you should have an idea what are you going to look for. So therefore, first of all, you have to divide the liver function test into certain categories. So first thing is whether it is something related to hepatocyte injury, whether it is something related to synthetic dysfunction of the liver, whether it is related to some abnormal biliary drainage, either mechanical or immune damage to the biliary system. So when there's a hepatocyte damage, that would be represented by elevation of ALT and AST. So when there's a synthetic dysfunction, that would be represented by elevated bilirubin, albumin, reduction of albumin with alteration of albumin globulin ratio and PTINR. When there's a biliary pathology, so it would be represented by alkaline phosphatase, elevation of alkaline phosphatase and gamma GT, as well as serum bilirubin to a certain extent. So, however, that is not that crystal clear. You don't have that elevation of AST, ALT with normal bilirubin and alkaline phosphatase in most of the instances. So there may be combination of abnormalities. So how do you evaluate such conditions? So therefore, you should have an idea, especially the junior doctors should have an idea what to do next. So what investigation should be ordered next. So if it is hepatic, as I mentioned, the elevation of transaminases are disproportionate to the elevation of alkaline phosphatase and gamma GT. You can have transaminases of maybe 500, 600 with alkaline phosphatase 2 times the upper limit of normal. So check the proportion. The proportion of elevation of transaminases are much greater than the proportion of elevation of alkaline phosphatase and gamma GT. Because you can't have normal alkaline phosphatase and high transaminases even in hepatic conditions. There could be hepatocyte swelling, so you can have a little bit of biliary canalicular type of obstruction. So therefore, the proportion is important. When there's a cholestasis, yes, you can have disproportionate elevation of alkaline phosphatase and gamma GT. Yes, that's true. You can have some elevation of AST, ALT, but when you compare the proportion, so elevation of alkaline phosphatase is much greater than the elevation of AST, ALT. But you can have some mixed type as well. So the proportion more or less equal. So that could be mixed type. So not only that, so you can determine, you can get an idea what sort of a liver disease, whether it's a chronic liver or an acute liver. So AST, ALT the level may not be important in chronic liver disease. It could be absolutely normal. So just passing the liver profile with normal AST-ALT is very dangerous, because what you have to check is the ratio. So ALT-AST ratio is important. As you know, ALT is liver specific, where the AST is produced by liver, skeletal muscle, heart, and so many other red blood cells and so many other tissues as well. So once the liver is damaged and the fibrosed, the hepatic production of the ALT goes down, whereas the AST production remains more or less same, because there are some other sources. So the ratio is important rather than the absolute value. So we all know the serum bilirubin goes down. What is reversal? Is that elevation of globulin or normal albumin, or is it normal globulin with reduction of albumin? So actually it is reduction of albumin with more or less normal globulins. That is that is the reversal. So you can have normal albumin with elevated globulins. That is not reversal, because why? There are certain other medical conditions you can have elevated globulin. So that is not reversal. So elevated serum bilirubin and elevated serum PTINR. Whereas in acute liver disease, acute liver injury, you can have very high AST-ALT level or modest elevation. There are only four diseases or 4 clinical pathological causes where you can have ALT-AST of thousands. If it is more than thousands, it could be either drug injury, could be either ischemic, could be viral, could be toxins. Most of the instances, 99.9%, if it is more than thousands, you should arrange your next set of investigations focusing those differential diagnoses. In the resource poor setting, so we know how we are struggling. Dulani knows, our virologist knows how we are struggling with investigating patients. So just seal all the investigations, including cerebral plasmin, blah, 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 can be done by my ward attendant. But you are here not to do that. That's why you need this knowledge. So elevated serum bilirubin could be there in acute liver disease. However, if the acute hepatitis progress towards the fulminant liver failure, then the synthetic functions are going to be affected. So therefore, if while you are doing the next day ward round, the patient's INR, which had been normal, tend to rise. So that is an alarming sign. So you might have to do something. So if the synthetic functions are also affected during the episode of acute liver injury, that is one of the worst prognostic factors one can have. So not only that, the evaluation of the AST-ALT, the liver profile, full liver profile itself will narrow down your differential diagnosis. That's why it is important. Just checking the AST-ALT, you can exclude some other differential diagnosis, or you can consider most likely differential diagnosis. The modest elevation of AST-ALT could be due to autoimmune, could be due to Wilson's, could be due to hemochromatosis, hepatitis C, and NAFLD. This modest means several hundreds, usually not more than thousands. So AST elevation of AST more than ALT, if it is more than 2 times that of the ALT seen in patient with alcoholic hepatitis, if you see such a report, always you have to check what the gamma GT is. So that might confirm that this is due to alcoholic hepatitis, because we don't have alcohol levels available in our country. So we need our clinical judgment and some biochemical suspicion. And reversal of AST-ALT, I told you, could be due to liver. So I have got so many referrals with high AST with normal all other liver functions, asking my opinion or someone's, maybe physician's opinion. So what's that? We don't have to think about the liver. We have to check the muscles. It could be myositis. Could be a late presentation of cardiac event. what could be cell lysis. So you have to focus on your next set of investigation on that line. Otherwise, you might be missing most of the dangerous diagnosis. Therefore, please think about that as well. So disproportionate elevation of alkaline phosphatase and gamma GT could be due to biliary obstruction. It could be mechanical, it could be medical. So having those informations in your mind, we'll move on to the NAFLD, NASH, and fatty liver disease. The NAFLD is, we all know, it's an umbrella term. There's no specific disease entity which is described by NAFLD. The most benign end is steatosis, the pure steatosis. And it would progress to NASH, which is inflammation, and certain group of patients who are having NASH would progress into fibrosis and advanced cirrhosis. So this is how the histology shows us. The NAFLD is just the fat accumulation in hepatocytes. The hepatocytes looks whitish, like whitish globules, where the inflammation is there. The inflammatory cells are infiltrate. Apart from the fat deposition, then there will be hepatocyte injury, and there may be mild degree of fibrosis as well. Once the fibrosis progresses, then patient develop bridging fibrosis and nodular formation, which is sort of an advanced form of fibrosis or NASH. So most important thing is, when you see a report, the ultrasound report of fatty liver, that doesn't say it is fatty liver. Yes, you can diagnose fatty liver. The ultrasound is the most sensitive and reliable method of fatty liver. But medically, this could be due to so many other reasons as well. The fat deposition in the liver is not purely due to metabolic syndrome itself. So when you see a report with fatty liver, it could be due to simple steatosis. Steatosis is mild lobular inflammation, or it could be early NASH, even with fibrosis, because ultrasound is not sensitive enough to detect fibrosis, early fibrosis as well. Yes, it would detect cirrhosis and some structural changes, but not NASH or steatosis. On the other hand, the fat deposition could be due to AFLD. Alcohol is one of the main risk factors for the fat deposition in the liver, which is called alcoholic fatty liver disease. Or it could be due to drugs. There are certain drugs, hepatitis C, hemochromatosis, autoimmune, celiac, Wilson's, A-beta lipoproteinemia, hypopituitarism, starvation, and so many other diseases you should consider according to the clinical circumstances. So we all are interested maybe about how much of safe drinking is. So it's just about 568 milliliters of beer, 4% beer, and just 25 milliliters of spirit per week. So that is the safe. Beyond that, that might cause liver damage. So what is NAFLD? There had been a that intense argument and discussion. There is no disease entity called NAFLD. This is all NAFLD. So we don't know. We are still not sure whether there is NAFLD or NAFLD. So NAFLD is hepatic steatosis in adults along with features of metabolic syndrome. Either they should have overweight or obesity or type 2 diabetes. So if those disease entities or diseases are there along with NAFLD, that is called MAFLD. Some clinicians believe that, some does not. I don't know. So, but still the people are not sure about this MAFLD or NAFLD theory. So, however, there are some group of people, those who are lean with normal body weight, they also can, whether they can have NAFLD or MAFLD. What is that? So, those lean NAFLD patient, if they have, that impaired glucose tolerance, hypertriglyceridemia, the diastolic blood pressure, any two clinical criteria of metabolic syndrome, they can be grouped as considered as NAFLD as well. So not necessary to have overweight, obesity, or type 2 diabetes. So still not sure whether we have to call it NAFLD or NAFLD. So let's discuss something about guidelines. So guidelines mainly focus on screening, evaluation, natural history, and treatment. So about screening, so it is not recommended for you all to screen, arrange any community screening for NAFLD, because one thing is it's really cost effective, the cost effectiveness. The other thing is whether we do have any sort of a therapeutics, any effective therapeutic strategies to overcome the problem. Still, it's doubtful. So, however, the patient with insulin resistant or metabolic syndrome like obesity should be undergo screening for NAFLD. And you have to screen individuals' steatosis with secondary causes of NAFLD as well. So the careful assessment of alcohol intake should be done. Always consider interaction between moderate amount of alcohol and metabolic factors, because most of the people, they do take alcohol moderate amount on top of some metabolic features. We are not quite sure this is alcohol or metabolic. So there may be some augment effect on both etiologies. So value of screening NAFLD in community is limited, as I told you. However, all individual steatosis should be screened for metabolic syndrome, and all individual with metabolic syndrome should be screened for NAFLD. So since it is well interconnected. So what is the pathophysiology? As we all know, it's multifactorial. Mainly the culprit is the sedentary lifestyle and the diet. So high calorie intake, excess saturated fat, high fructose intake, and sedentary behavior. So genetically, PNP LA3 and TM6SF2 genes are blamed for the development of metabolic syndrome and especially NAFLD. But genetic screening is not recommended unless for sort of clinical studies or some other clinical purposes. It's not recommended. What is the natural history? Yes, we know. So how common this fatty liver is? If we arrange an ultrasound scan, most of the time the report would be that the person might be having fatty liver steatosis. However, 12 to 40% of patients with fatty liver would progress into NASH, and from that another 30% would develop advanced fibrosis, and from 50% of patients with advanced fibrosis will be ended up with cirrhosis. And overall, the 14% of this patient, those who are having either NASH, advanced cirrhosis or cirrhosis, will need either liver transplant or will lose them. And 7% of them would develop hepatocellular carcinoma. So how to evaluate? How to evaluate steatosis? Still, the ultrasound is the gold standard way of screening or diagnosing steatosis, that means the fatty liver, and it's very cost effective once the resources are there. The liver biochemistry may be elevation of AST/ALT, gamma GT, or any increase of AST/ALT or gamma GT could be there. Steatosis biomarkers are not very much validated. There are several biomarkers: steato index, NAFLD fat score, and fatty liver index. Those are not very much validated for steatosis. Don't confuse about the terms. And if you need to quantify fat, how much fat is there, the MRI is the best. Because steatosis is defined by the presence of more than 5% of the fat in the liver. The liver weight, out of the liver weight, 5% is fat. If it is more than that, that is steatosis. So how do you evaluate fibrosis? There are some non-invasive ways as well as invasive method. The biomarkers are validated for the diagnosis of fibrosis and NASH. I will let you know what the biomarkers. And transient elastography is one of the most reliable and non-invasive way of detecting liver fibrosis. So it is available in our country. So, however, the liver biopsy remains the gold standard method of detecting fibrosis or the inflammation. So, ultrasound is the preferred first-line diagnostic procedure for the imaging of NAFLD. Whenever the imaging tool is not available or feasible, serum biomarkers and scores and the acceptable alteration can be considered for the diagnosis of steatosis. The steatosis, the ultrasound is the best. So, non-invasive assessment of fibrosis, because fibrosis is the most important prognostic factor in NAFLD. If someone has got fibrosis, they are at a high risk of developing cirrhosis or hepatocellular carcinoma, or they might need transplant someday. So, biomarkers, fibrosis score and the transient elastography are acceptable non-invasive procedure to identify those who are at low risk of advanced fibrosis or cirrhosis. If the fibrosis risk is low or advanced cirrhosis risk is low, the biomarkers, fibrosis scores and transient elastography is one of the reliable method. The biomarkers and scores plus transient elastography might confirm the additional diagnostic accuracy. If you combine both together, it might give you some additional diagnostic accuracy and reduces the need of liver biopsy. However, the monitoring of fibrosis progression may rely on biomarkers or the score or the transient elastography need to be further validated. We are not quite sure about that. The identification of the advanced fibrosis or cirrhosis by biomarkers or scores may be less accurate. So I'll let you know. So those are the biomarkers. Please use these biomarkers when you see a patient with fatty liver disease, because this will reduce the unnecessary request for liver biopsies and unnecessary investigations. This is very simple. The fourfold score is one of the most validated methods for you all to diagnose NASH or the fibrosis. So what do you need? Need is the age, AST, ALT and the platelet count. It's very straightforward. So it's available, freely available, everyone can afford and calculate the fourfold score. So then I will let you know what to do, because other scores are a bit complicated, but it's not that much. If you consider NAFLD fibrosis score, the age, hyperglycemia, BMI, platelet count, albumin, AST, ALT ratio. So a bit complicated, but still can be done. So what are the biomarkers for the liver fibrosis? That commercially available biomarkers, fibro test and enhanced liver fibrosis test, not in Sri Lanka but in other countries, not much validated as other biomarkers. So non-invasive assessment of the fibrosis, apart from the biomarkers, the most reliable method is the transient elastography, which is an indirect way of assessing the liver stiffness using some ultrasound waves. We assume that the liver stiffness correlates with the degree of the fibrosis. But we have to use this phenomenon with a very good clinical sense, because you know liver could be stiffened by some other methods as well, but not only the fibrosis. So that's why you all clinicians are here, for you to interpret the report rather than treat the report. So on the other hand, the transient elastography is most effective and validated method, and it is help you to rule out fibrosis rather than rule in. So if it is negative, yes, it is negative. But if it is positive, then you have to work it out. And the cutoff varies. There's a doubt about the cutoff values yet. Because this transient elastography was better validated for viral hepatitis and fibrosis, in the viral induced fibrosis like Hep C, HIV and Hep B rather than NAFLD. When you interpret the transient elastography, you should remember what the serum aminotransferases levels are. Because if it is more than 5 times the upper limit of the normal, there should be ongoing liver inflammations. Once the inflammation is there, anyway liver is stiff. So when you interpret the report, you should always go through the liver function test. Correlate the report with the liver function test. Then there should be absence of extrahepatic cholestasis. Once the cholestasis is there, definitely is very simple. Biliary canaliculi are filled with bile, so the liver is stiff. So it will be interpreted in a wrong manner. So absence of heart failure, any liver congestion, the Budd-Chiari syndrome, heart failure, whatever. So the liver is stiff because of the vascular congestion. So absence of ongoing alcohol intake, those things should be excluded prior to interpreting elastography. And if the patient is obese, BMI is more than 30, report may not be that reliable even if you use the extra large probe. And the uncontrolled diabetes as well as advanced NASH. So this is what you should do. I just want to emphasize. So calculate the FIB-4 score. So this is the FIB-4 score. So it is very simple and straightforward. If the FIB-4 score is less than 1.3, is low risk. Just discharge the patient from the clinic and ask them to come in about 2-3 years time. So it is that simple. So the FIB-4 score is 1.3 to 6.27 with high metabolic risk. Age is more than 40. You have to go ahead with either MRE if possible and elastography, transient elastography. If the elastography shows the score is less than 7.7, again it is low risk. Discharge the patient from your clinic and re-evaluate the patient in 2 to 3 years time. So if not, if it is intermediate risk, the elastography score is between 7.7 to 10.35, might consider liver biopsy, or you have to, as well as you have to manage cardiometabolic risk factors as well. The FIB-4 score is more than 2.6, and those are the patients who have a high risk. That kind of patient needs close observation, might need liver biopsy for the confirmation of the cirrhosis or exclude other causes, and might have to refer to a tertiary care center. So therefore this can be done by whatever the peripheral hospital. Okay? So it is that simple for you to determine the plan out the management of fatty liver disease. The liver biopsy is essential for the diagnosis of NASH. Yes, true. So NASH requires, diagnosis of NASH requires steatosis plus lobuloportal inflammation with ballooning. So what is the fibrosis? The fibrosis again can be divided into certain stages. So because this is important for us to determine the medical management. So if the fibrosis score is 0, if someone says whatever the elastography or the biopsy says the score is 0, there's no fibrosis. 1, the mild, 2, moderate, 3, severe, and 4, cirrhosis. So this is the group we have to be more careful about, and this is the group who needs more protective measures. So the management, as we all know, it closely related to the unhealthy lifestyle. The diet is important, so we need individualized type of a lifestyle modification, because the blanket management may not be applicable for each and every patient. So dietary recommendations should be considered energy restriction and exclusion of NAFLD promoting components like processed food and beverages, high added fructose, and macronutrients composition should be adjusted according to the Mediterranean diet. Both aerobic and resistant type of exercises, both exercises going to be effective in terms of the management of NAFLD and steatosis. So we have to consider energy restriction, hypocaloric diet, macronutrient composition, low to moderate fat, moderate to high carbohydrate, low carbohydrate, ketogenic diet, low high proteins. The fructose intake should be reduced as much as possible. The daily alcohol, we know how much we are allowed. And coffee consumption, no liver limitation. Physical activity 150 minutes, moderate to intense 3 to 5 days. Resistant training to provide musculoskeletal fitness, improve the metabolic factors, because that is also important, which is something new, because just the aerobic is not going to be that effective, especially in tackling insulin resistance. You need some sort of a good muscle bulk. So if you can achieve weight reduction by 3% of the existing body weight, you would be able to achieve 35 to 100% reversal of steatosis. If you can achieve more than 5%, inflammation ballooning would go off by 41 to 100%. If you can achieve more than 7% weight reduction, then there will be NASH resolution as well, 64 to 90%. If you achieve more than 10% of the body weight reduction, even fibrosis is reversible. So therefore, you have to be much more concerned about the weight reduction. So when to treat? We also patients are very happy to take a tablet and go home, because this is considered the most easier to stay. But pharmacotherapy should be reversed for patient with NASH. Don't prescribe vitamin E or whatever when you see a patient or report with fatty liver disease. Useless, SATA waste. So should be reversed for patient with NASH, particularly for those with significant fibrosis stage 2 and higher. Patient with less severe disease but higher risk disease progression could also be considered, like insulin resistant, obesity, other metabolic risk factors. Those who are not engaging with proper lifestyle modification, then you can consider. So there are certain options available: insulin sensitizers and antioxidant vitamin E. Because from country to country, the organization to organization, the recommendations are different. So if you check all the global recommendations, there's no confirmatory recommendation can be made on pioglitazone, vitamin E or the combination for the treatment of NASH, because it depends on where you work and where you practice. It means the where you feel what you follow. The optimal duration of therapy is not known. However, statin may be confidently used to reduce LDL cholesterol and other cardiovascular risk factors in NASH or NAFLD or steatosis. Therefore, don't be reluctant to start or continue statin in a patient with NAFLD or NASH. That if you do that, if you stop NAFLD, or if you stop statins, so the patient would be he might develop cardiac or any cerebrovascular complications rather than liver complications. So this is one of the way you to evaluate each and every available drugs. Metformin is good drug for as an insulin sensitizer. There are multiple studies. It's not recommended. Pioglitazone, 5N study to improve the steatosis without worsening fibrosis, may be used in patients with proven NASH, especially those who are having insulin, those who are having impaired glucose tolerance and diabetes. GLP-1 receptor agonist, the lean trial reduces NASH without worsening fibrosis, but we don't have much clinical evidence for you all to consider GLP-1 at the moment. Vitamin E, antioxidant, and which improves NASH without worsening fibrosis, may be used in non-diabetic adult patients with proven NASH. So I don't know why they have selected non-diabetic, because we don't have any clinical studies done on patients with diabetes. So other drug is obeticholic acid, which is one of the latest trial, regenerate study, which shows obeticholic acid 25 mg significantly improve fibrosis with no worsening NASH among patients with NASH. So if you see, 25 mg improves significantly the fibrosis in patients with NASH and fibrosis. However, the main problem with obeticholic acid is pruritus and the cost. So usually what we prescribe is 10 mg. Prescribe is 10 mg. It works, but we can go up to 25 mg. But it costs about maybe 500 to 700, maybe more than that, rupees per day. The surgery, the bariatric surgery, an option for the patient with unresponsive lifestyle changes and pharmacotherapy, which reduces the weight and the metabolic complication. The NAFLD associated cirrhosis is one of the top 3 indications for liver transplant in the world. So, just to summarize, screening is recommended for patients with metabolic syndrome. The fibrosis assessment, you can use FIB-4 score for patients with suspected NAFLD or NASH. Pharmacotherapy, no specific recommendation for steatosis, but the lifestyle modification, mainly the Mediterranean diet, avoid processed food and fructose. And pharmacotherapy, vitamin E 800 mg international unit daily can be considered non-diabetic patient with proven NASH without cirrhosis. Pioglitazone 300 mg daily can be considered in patient with and without type 2 diabetes mellitus with proven NASH. Pharmacotherapy should be reversed for patient with NASH, especially fibrosis grade 2 or more, and patient with metabolic risk factors. Pioglitazone recommended only in patient with, this is according to the EASL guideline, pre-diabetic or diabetic NASH for short-term use. Recommendation can be made regarding the use of vitamin E due to insufficient evidence according to the Asia Pacific guideline. The third column is the Asia Pacific guideline. The first column is the ASSLD guideline. The mid column is the EASL guideline. So there are several different recommendations given by several colleges and associations. But basically, what you can do is calculate the FIB4 score. If the fibrosis is more, if the score is more than 1.3, you don't need any action. If it is less than 1.3, if it is between 1.3 to 2.6, that kind of patient need further evaluation with elastography. If it is more than 2.6, such kind of patient might need biopsy. If the fibrosis is more than F2, that kind of patients might need pharmacotherapy along with lifestyle modification. Thank you.
Thank you very much, Udaya. Any questions? I'm sure there must be a lot of questions. Thanks, Udaya. Excellent protocol generated. Talk about this NAFLD. From the primary care physician point of view, I have the concern that we love to develop. I have few questions as well because we had in 2016 the NAFLD group respect to the FIB score. They are follow up for 10 years. So they assess their mortality compared to normal population. Their mortality is more than 10 times. And after the 10 years, they are looking back what is the cost of the mortality. 83% of the time, 87% of the time is some cardiovascular or malignancy related. And 13% of the time is related to the liver pathology. So that's why that's a more we have to highlight the primary care. Either your peaks, either your peak scores may be the state or low risk, may be moderate risk, may be high risk, but the cardiometabolic risk is same. So that's why you report to the diagnosis without practice. You diagnose the patient is stage 1, you can refer back the patient to primary care physician, but with the same risk of cardiometabolic risk. So that's why in the 2021 European PSC calculator card is recognized. So this is a NAFLD, is a major risk factor to the cardiovascular. So adding to the Indian studies, not only that, more than 33% of our community is a better for NAFLD too, or maybe even the better for it. And really, we have to go advanced achievement for the non-form the large majority. But I'm still in the 2020 recognized as our environment now polluted. We all have to look at we are in my equivalent somehow of our smoking equivalent. So that's not the all the rest. Again, the Asian point of view, all the patients are qualified for static because if you want to be still inside and contribution, all the patients are static. So in fact, this year, last year, probably the American Association of the Diabetic Guidelines, it's highlight value of the pioglitazone and then for GLP only for diabetes, not for other. And even because the high cardiometabolic risk, all the patients with diabetes, first line indication for HDL2, and again, you said, I don't know what is the reason. It will be only more than non-diabetes. Otherwise, the cornerstone of the treatment is lifestyle. So that's why we will come in. Then I will start with my first question. What do you think? Then you mentioned the two types, the European side, large diabetes, but the B being the Middle Indian Asians, they are lead probably the NAFLD, and they are going to the same journey with different journey.
Actually, this first comment is very important. That's why I highlight most of the time this fatty liver, the MAFLD or NAFLD, the mortality is not mainly due to the liver itself. So the main cause of the mortality is either cardiovascular or CVA. That's why most of the patients I have seen, most of the doctors, they have stopped statins. Just seeing the ultrasound report which shows fatty liver. So please don't do that, because it is confirmed that which is well connected to other metabolic risk factors. And what I mentioned, that the FIB4 scores 1 point less than 1.3, liver wise he is safe, but not otherwise. So he should go to the whatever the physician or maybe the cardiologist or the internal medicine physician to follow or assess other components, maybe heart or the cerebrovascular system. So with regard to your question, so still there's a doubt whether there's lean NAFLD exist or not. So there had been a lengthy discussion about 3 months ago in Europe with some leading physicians there. So some people doesn't believe that there's a group called lean NAFLD, but some do. And what my experience is, most of the patient with the NASH, those who are lean, has a bit of a worse prognosis than those who are obese. So maybe due to genetic component. But none of the guidelines recommended to check the genes for such kind of patients, because we can explain the obese patient with NAFLD or NASH, but the underlying pathophysiology is, but not the lean patient. So what one group believe is they are born small, maybe, so they have gained significant weight during their adolescence. So still they are within the recommended BMI, but if you compare the weight gain, the birth weight and the weight while they were in their adolescent, there's a drastic weight gain. That must be the reason for the visceral obesity. What they suspect is, I don't know. I can't have a solid answer for that question.
Second question is, because we know the Indian frequency disadvantage, there's a more sugar benefit of the other than the that is a lot of Americans, they go to some German, they use that because they are the Turkey. So what's your opinion about the Turkey?
Actually not been included to any sort of a guidelines. We have not practiced here, therefore I'm not quite sure about that. So I actually met the person who did the several times, who did the research on vitamin E and non-diabetic NAFLD. He's an American physician. So what he told me was, there's a forum in Colombo. So what he told me was, he was a bit reluctant to recruit diabetic patients because he was not sure about the impact of the vitamin E on other metabolic component, the cardiovascular risk and other risk. He was not a bit reluctant. That's why he didn't recruit. He also said us that there's no solid reason for me to exclude diabetic patients from this study. So he invite our people, including the endocrinologists, to consider that this study to recruit diabetic people as well, because there's no solid reason.
The Germans make use the curcumin.
Yeah.
So even if you are starting the curcumin as a infusion, there's a regression of the liver fibrosis also.
Yeah.
But so opinion of the curcumin.
Actually, I'm not quite sure about that, because I'm not much aware about that, because we use that Sri Lankan indigenous medicine people use some sort of another component which is called, can't remember, and but clinically we don't have much evidence for you all to consider these things, because we need actually good quality trials for you to give us a recommendation, but I'm not quite sure.
One thing, IOPAThy was that our cancer is not always be acting the Western guidelines. So maybe always we use our avocado like a current beer. So now we change into the dry powder. When you dry powder, we will not get the turkey. The word right of the is turkey, it is a very liver friendly. The reverse, the liver fiber. Our avocado is very use turkey as a bit of infusion. Not about it. It's not coming to the guideline, but it seems to be
The other thing is a heme bovity. The people also believe that he.
question. You had that chart, the pyramid with the reduction in weight. Do you recommend that for ideal body weight people or only for obese people?
So
That chart.
actually,
For NASH.
so if our BMI recommended BMI is lower than that of the European, so if it is more than that, you need to achieve that target. For the lean NASH, still what they recommend is, if possible, you have to achieve at least 5% of the recommended chart, because they believe that they can have visceral obesity. So the engaging with aerobic and muscle building exercises are recommended for all patients with NAFLD and NASH, irrespective of the body mass index.
So the weight loss also you recommend even for
50% of the recommended chart.
Any other question?
About the duration of exercise,
The 150 to 200 minutes per week. That is minimum. If you can do more than that, that will be beneficial.
Any other question?
so now they have done the trials in India for the diabetic group who are, who are having the level. So they have proven that vitamin is also we can prescribe for the diabetic group with evidence. But unfortunately, it has not come to the international guidelines. But India, they are practicing. So they have proven. Only thing is that unnecessary. Some people that just because of the transcendent, as Dr. Palwal said correctly, that because of we have to try lifestyle modification first. And if he, if the patient is diagnosed to have the NAFLD or biopsy, then there is a place for the farm. So in that group, you can give the vitamin E, but keep in mind that there are a lot of side effects of vitamin E, like emergency stroke and prostate.
Yes.
So if you are going to start the vitamin E on a young patient, you have to be very careful because we might have to give for few years. Sometimes even the whole life we might have consider because there are no trials. There is no recommendation when to stop.
Yeah.
So that's the problem. So that's why we have to be very careful. But there are evidence that we can give vitamin E in the diabetic group.
So actually, we are misusing vitamin E
Yes.
nowadays, because most of the patients are on vitamin E. Nobody knows what the duration, and they are keep on taking vitamin E. So it might be a problem, because we don't know the actual side effect profile and those things. Correct, that Chandra correctly mentioned.
Any other question?
And yeah, and the other thing that there is that study. So if we see a slight transaminases in a patient with an apple, conventionally we try to stop the study. But by practice, with experience, we know that if we start study on an apple patient, there is the reduction of transaminase. But there's a theory that conventionally, if it's a 3 times high elevation of the transaminase, we should not start. But if they are only studying, there's no reason to stop it. So better to continue, or either you can start study on a patient who has got at least few metabolic risk factors, because there's a definite reduction and a definite benefit of giving the study in a NAFLD patient. Because at the end of the day, NASH patients they will require liver transplant. You should have a good cardiovascular stability. So if the heart is not working properly, you can't go ahead with the definitive treatment of liver transplant. So you should have a good heart prior to the transplant. So better to continue study. As much as possible, because otherwise your heart will get compromised at the end of the day.
Just to add on one thing, the statin-induced liver injury is due to idiosyncratic reaction. So the idiosyncratic reaction, the prevalence, the incidence of idiosyncratic reaction due to statin-induced liver injury is same as that of diclofenac sodium-induced liver injury. So nobody is going to check AST/ALT once you start diclofenac sodium for a patient, but we used to check AST/ALT after starting statins. This is useless.